Thank you very much. It's a pleasure and a privilege to be here representing the team at TRI to discuss VTE as a chronic illness and the implications for extended duration anticoagulation. Here are my disclosures. And one of the important objectives of Garfield VTE is to obtain at least 3-year follow-up in the cohort to determine whether VTE is a chronic illness that warrants extended duration anticoagulation beyond 3 to 6 months. And this will include our tracking patients who have an initial VTE event to track them after anticoagulation is discontinued to determine whether they have a recurrence over the ensuing 3 years. There are several emerging hypotheses. First, that VTE is, for the most part, a chronic inflammatory illness, much like myocardial infarction, coronary artery disease, or diabetes mellitus. And that VTE does not really disappear after 3 months of anticoagulation, but that in many instances, VTE continues to lurk subclinically, waiting for the right circumstances to recur. And therefore, there is the emerging thought process that VTE requires lifelong attention to risk factor reduction with heart-healthy lifestyles, such as exercise and nutrition, and at times with medication. There are a lot of previous registries that have looked at the likelihood of a recurrent VTE event after the discontinuation of anticoagulation. Here is one registry from the United Kingdom, and you'll see in red is the unprovoked VTE rate 10 years after cessation of anticoagulation in patients with unprovoked VTE. In this registry, the recurrence rate was 30%. In other registries, the recurrence rate after unprovoked VTE 10 years later, following the cessation of anticoagulation, is as high as 50%. For provoked VTE in this registry, and I think in this registry the most common cause of provoked VTE was surgery in the post-operative state. There was about a 20% recurrence over the ensuing 10 years after anticoagulation was discontinued. We used to think we could stratify and predict who was going to suffer a recurrent VTE episode simply by obtaining a D-dimer assay at the conclusion of the 3 to 6 months of traditional anticoagulation. But this study from McMaster shows us that the D-dimer really disappoints because it does not reliably exclude those patients who are at risk of suffering recurrent VTE. In this study of patients with unprovoked VTE, they had an average of 5 months of warfarin treatment, and then they had D-dimer testing. The thought was that if the D-dimer was negative and low, then that they would not have a recurrence and they did not need to resume anticoagulation. But in fact, among the men, over the next year, 1 year after cessation of anticoagulation, 8% of men and 5% of women suffered a recurrent VTE event, even though the D dimer was negative. And of course, if they had an elevated D dimer level and they did not resume anticoagulation, their event rates were twice as high, 16% per year in that first year after stopping anticoagulation for men, and 10% recurrence rate in the first year after stopping anticoagulation for women. Another study from France is the PADIS-PE study, which compared patients randomized to 6 months versus 24 months of warfarin therapy to treat pulmonary embolism. And the goals of this study were to prevent recurrent pulmonary embolism after an additional 18 months of warfarin compared to the more traditional 6 months of warfarin treatment, and then to follow both groups, the 6-month group and the 24-month group, for an additional 2 years after both groups had completed warfarin therapy to determine the recurrence rates during the ensuing 2 years when none of the patients were taking anticoagulation any longer. And this study was done with warfarin. What we see in the placebo group, this is the group that received only 6 months of warfarin therapy, is that immediately upon cessation of anticoagulation, their recurrence rate for pulmonary embolism began and was quite high. The group that received 24 months of warfarin, and after that additional 18 months of warfarin was completed, they suddenly had cessation of anticoagulation, and then for them also, the recurrence rate of pulmonary embolism was quite high, and they recurred at a sharper, higher rate than the group that only received 6 months, so that at the end of the 2 years of follow-up of both groups off anticoagulation, there was no statistically significant difference in the recurrence rate between the two groups. So the benefit of 18 additional months of warfarin was not maintained following cessation of warfarin, and the group in which extended warfarin was given developed new pulmonary embolism at a rate twice as high as a group that never had that additional 18 months of warfarin, suggesting the possibility of a rebound effect. A meta-analysis was done of studies using warfarin, comparing long-term extended duration warfarin versus short-term warfarin for treatment of VTE. And in this meta-analysis, there was an 80% reduction in recurrent VTE in patients while they were taking extended duration warfarin compared with no warfarin whatsoever. But with warfarin, this came at a price of safety. There was a 3.4 times higher major bleeding complication rate in the group that received extended duration warfarin therapy. The guidelines from the American College of Chest Physicians from 2016 state that if a VTE is unprovoked with low to moderate bleeding risk, the American College of Chest Physicians suggests extended duration anticoagulant therapy with no scheduled stop date for greater than 3 months of therapy. But on the other hand, if there is a provoked VTE, provoked by surgery or provoked by a non-surgical transient risk factor, that anticoagulation should be carried out for 3 months and should then be stopped. Well, The optimal duration of anticoagulation was explored further in the pivotal Einstein choice study. And here's a figure from the methods paper. And what it's really looking at is long-term prevention of recurrent VTE. Patients in this trial received 6 to 12 months of anticoagulation for DVT or pulmonary embolism, and then they were randomized to one of 3 treatment groups for the ensuing year: rivaroxaban 20 milligrams a day, rivaroxaban 10 milligrams a day, or low-dose aspirin once daily. Here the results are summarized. Rivaroxaban, whether given in a dose of 10 milligrams daily or 20 milligrams daily, had a 70% reduction in recurrent VTE compared to the group of patients randomized to low-dose aspirin. That was the efficacy side of the equation. On the major bleeding side of the equation, there was no statistically significant difference in major bleeding among any of the 3 treatment groups: rivaroxaban 20 milligrams daily, rivaroxaban 10 milligrams daily, or low-dose aspirin. All had the same major bleeding complication rate. And here you have the actual numbers from the Einstein choice trial, which was published this past March. Certainly the provoked VTE patients overall have a lower recurrent VTE rate than those with unprovoked VTE, who have a higher recurrence rate during that ensuing first year. But notice that the rivaroxaban groups, 20 milligrams daily and 10 milligrams daily, have in each instance, whether for unprovoked VTE or provoked VTE, a 70% reduction in recurrence compared with low-dose aspirin. The important point is that Einstein choice had 60% of the total population with provoked VTE and only 40% of the population with unprovoked VTE. Einstein choice was the largest extension study ever of VTE, and the largest extension study ever of provoked VTE. And rivaroxaban was equally effective in recurrent VTE risk reduction by 70% in both provoked and unprovoked VTE. Well, Garfield VTE will provide us with real-world data on whether extended duration anticoagulation therapy for VTE should be the default, unless the recurrence risk is very low or the bleeding risk is very high. And Garfield VTE bridges randomized pivotal trial data with real-world considerations. Thank you very much.